Thank you very much for asking me to present here on a topic which often we're left till last in the day, so at least I'm not the very last today. Motor neurone disease is complex. The healthcare systems that we work in are extremely complex. When there's a simple problem, we know what the answers are, we know what the rules are, we know what the outcomes might be. But as things become more complicated, more complex, often chaos may rule. And the complicated complex is where palliative care tries to fit in. Our name is not sexy. People actually don't want to see us. They fear us. We're not neurosurgeons. We're not surgeons separating Siamese twins. We're doing basic, good healthcare and talking and spending a lot of time with patients and families. Motor neurone disease is unpredictable. We know that there will be progressive disease, but what comes next and when will that come is unknown. It's dynamic, it's changing all the time. People can become so sick so quickly. And the outcomes that you derive will really depend on your interactions with the carers that look after you, the home care that you have, the after-hours care that you have access to, and what all the services bring to the table. I would argue that complex is not equal being too difficult. It is not too complicated, it is not too expensive. Often when people are saying it's complex, it's because they are overwhelmed or under-resourced. Palliative care focuses on patients who have complex needs. They may be physical needs, but they may very well be social, the spiritual, the psychological. And those last three are really what combines quality of life. If you look at quality of life in motor neurone disease, often it is maintained despite progressive physical impairment because the social, the spiritual, the psychological are being looked after. Importantly, palliative care aims neither to hasten nor prolong the dying process. Now, I appreciate there are a number of patients and carers in the audience who have already been challenged with a life-limiting diagnosis. What about most of us sitting here? Have we thought about what our future holds? How are we prepared for it? Have we discussed it with anyone? Most of us want to talk about it with our family, our friends, but we often never do until a crisis intervenes. And medicine hasn't taught us very well over the years either. It's often considered to be a failure in the care of patients. So often it's not talked about. Often doctors even think, well, if I talk about dying, I'm going to remove all hope from that person, so I won't talk about it. And it takes time too. So they're too busy on a ward round, so they don't ask the questions. And clinics are so overbooked that they don't ask the questions. Palliative Care Australia has a website called Dying to Talk, and it's a really good website, but there are others when you Google it about thinking about talking, thinking about preparing, making an advanced care directive. The World Health Organization definitions of palliative care is to improve the quality of life of patients and families. They say prevent suffering. I would prefer to try to minimise suffering. I try to smooth the speed humps. I try to make that journey a little bit easier. We assess patients as best as we can. We manage their symptoms, whatever they may be, and I'll talk about that towards the end of the presentation, but we really look after spiritual, psychological, social aspects as best we can. There are lots of myths that surround us. We do not hasten death. There's actually really compelling evidence to show that involvement with a palliative care service prolongs life. It improves quality of life, and it actually does it more cheaply. Palliative care is not just a name for euthanasia or assisted suicide. Whilst when I first started in palliative care almost 2 decades ago, it was predominantly patients with malignancies, about 20% of our patients now have chronic illness, heart failure, COPD, renal impairment and progressive neurological deficits. Not everyone who dies has pain. Certainly with motor neuron disease, we do see pain, and it's often under-recognised and underappreciated. Just that stiffness from not moving. Those joints get so stiff and uncomfortable that some simple physiotherapy helps keep that joint mobile. Morphine does not hasten death. In patients who have pain, good pain control actually prolongs life. It does not lead to addiction. And dying at home may not be the best answer for every patient. That the care, the embrace, the protection of a hospice may be what's best for that person and their family. I'm only talking briefly about voluntary assisted suicide because Professor O'Connor follows me. But these are my hopes, as it is legalised around this country, as it will do, that palliative care becomes mainstream as part of what we do in all healthcare systems, and that there is increased funding. They certainly did it in Belgium when they legalised euthanasia, and the Victorian government has committed from June for extra funding. We need absolutely rigorous credentialing and education and standards for those that are partaking in this. And importantly, bereavement services for families that have been involved with voluntary assisted dying, but the clinicians and staff associated with it are essential. So what might a good death look like? Karen Steinhauser in Focus Groups published this in 2000. What would a good death look like? Pain and symptom management I've touched on. People want to try to keep their cognitive state as clear as they can for as long as they can. They want to be able to prepare for a dying process. They want completion. That actually might be providing forgiveness or receiving forgiveness or tidying up loose ends, writing that biography. We have biography services in our palliative care team. Making a contribution, and I see this all the time with our research and our patients who actively partake in research. It may not help me, but it will help others. They want to be affirmed as a whole person, not just the person with MND or a pleural effusion, a whole person. The Grattan Institute, an Australian think tank, has their own list that they've published recently. Very similar topics. They want to know when death is coming, to maintain that control over what's happening. Dignity and privacy, to have choice. That emotional support is really very important. To have care in a location of your choosing, and to be able to issue advanced care directives. What I was talking about before, planning, discussing, sharing with others. Whilst that's the ideal, I do have concerns that we are not well funded in some aspects, and it varies from state to state, from region to region. The after-hours care service in South Australia is not well looked after. Our ability to provide after-hours medical or nursing cover is not well looked after. There are huge gaps in the system. If you go to a residential care facility, they are so overworked at times. And then our families are all getting smaller. Marie, I take my hat off to you and your family. I've got 3 daughters, but only one living in South Australia now because of work and study, and they're going elsewhere. So our families are very dislocated. And within our own neighbourhood, we're isolated. What used to be a community has become very much isolated. We do like control. We plan everything. We plan our holidays. We plan our birthdays and celebrations. We should be planning this. The spirituality of dying is really important, and we don't necessarily do it well. Patients with motor neuron disease They blow me away with their spirit, their tenacity, their strength. What keeps them going? And when I talk to patients about what drives them, what keeps them going, it might be a beautiful Melbourne spring morning. It might be seeing that sunrise and listen to the bird song. It might be some classical music. It's what drives that person. That's what spirituality is. It's not just religion. But among all of those other dimensions, there is that validation, being forgiven for mistakes that I've made over my life, a peacefulness, a permission to leave the world. And from clinicians' perspective, these are some of the questions that you might utilise in how to raise a discussion with a patient. What do I need to know or understand about you so I can best look after you? What's important to you? What gives you pleasure? What gives you that strength? And importantly for many, religion and faith is that important. Particularly in the dying process, in the immediate after-death process, there are very much some religious and faith practices that need to be adhered to. A whole talk could be devoted to caregivers and the exhaustion that comes with it. Marie demonstrated that this morning. It is exhausting. It is relentless. There is increased isolation. There is increased mental health issues. Carers describe sleeping with one eye shut. They're always on guard, always on duty. We take it for granted when we wake up, roll over and get comfortable, but when you have to be manhandled to become comfortable overnight and the carer has to do that, everyone's awake in the family and they are exhausted. And that's what specialist palliative care does. It musters support around that caregiver, the social aspects, the psychosocial aspects. But we do need to do more work on it. And whilst as a disease progresses, there is increasing physical impairment, it's the cognitive behavioural aspects that are so pressing on families and their carers. So we need to do more work on that aspect of patient care and family care. How do we help provide care and support for caregivers? The multidisciplinary team is part of that, and I would argue that as a disease progresses, that's where the specialist palliative care teams come into their own, because we have social workers, allied health workers, complementary care workers, we have chaplains, we have a whole team surrounded in us and bereavement workers, but we're not as well resourced as we would like to be. These are some of the things that I deal with when I talk with patients about what's ailing them, but it's not exhaustive. I do spend a lot of time talking about initiating and when is it appropriate to withdraw from ventilation and artificial feeding. I look a lot at pain management, breathlessness. You know that it's in the guidelines that you use morphine for breathlessness and benzodiazepines. There has never been a randomised controlled trial. It is all anecdote. Mental health issues, communication, speech we've heard about. The frontotemporal dementia and the impact on family care. Advanced care planning. Where might we look after this person? So I've touched on a lot of things, but only given a little bit to each one. I hope I have demystified and removed some of the stigma from palliative care, that we do more than those last few days of life, and that early referral to palliative care may improve quality of life for patients and families. And when your neurologist or your speech therapist or your physio says, I think we need to refer you to the palliative care service, you may embrace that for what the team has to offer, but not fear us, because we are more than the last few days of life. Thank you very much.